assignment, and it was an assignment, from Dr. Means was to talk about hydrocephalus in the newborn, and I will do that. Since I'm a surgeon, I will use small words and lots of pictures. And we have about 30 minutes. So, all right, what is it? What causes it? Signs and symptoms, diagnosis, treatment, and go over a few cases to drive the concepts home. So everybody knows the brain has ventricles, they're full of water. You make 2 cups of water a day in an adult, and it circulates around from the inside to the outside, gets absorbed mostly on the surface. Hydrocephalus is some screw up of that process. So the keys to hydrocephalus is it is changes over time. It's not what the brain looks like at any moment. It's what it looks like today versus previously. The static size of the ventricle doesn't actually really matter. It is treatable, and it will damage the brain or kill you if you don't treat it. And the timeline for treating it is quite variable from person to person. Causes in the newborn. Not everybody else. We're not worried about that today. IVH is definitely the biggest player for us. Spina bifida, some congenital malformations, infection for the poor newborns who get an infection, and trauma and tumor that really don't play a role for neonatal hydrocephalus. You need time for trauma to happen, and you need time for tumors to grow. So we won't talk about them at all. Alrighty, so signs and symptoms. We're going to go through the really important ones. Head size. All the pediatricians in the room have been building these charts, measuring little heads. And if you follow a percentile curve, everything's great. If you start high and stay high, that's okay. You start low and stay low, that's maybe not great, but it's not hydrocephalus. This is a problem. This is an actual patient. We'll look at his brain later. So we, neurosurgery, met him here, 5 years old. And he'd been seeing the same people, and they were dutifully recording his head size for years. It would have been better to see him here, but anyways, we met him here, and we'll see his brain in later. All right, head size is important. Sometimes it's pretty obvious. The tiny face and the light bulb head, that's hydrocephalus until proven otherwise. If you have a patient with a really big head and a big face, look around the room, it probably looks like Dad, and that's probably normal. But the small face and the big head, that's trouble. The fontanelle, the pressure monitor of infancy. If you touch the when the baby's quiet and happy, you should be able to feel the bone edges. If you can't feel the bone edges, there's something cooking. If the baby's crying and screaming and pooping, you don't worry about the bone edges, you won't feel them. Sometimes the fontanelle is real obvious, like that guy. Oops, oh man, sorry about that. Real obvious, but mostly in a kid with a brewing hydrocephalus, it's just kind of a soft bump like that guy, and he doesn't seem to be bothering him, but it is. It can be pretty subtle. Scalp veins, really blue and lots of acute angles. That's hydrocephalus until proven otherwise. If you're an old, like the old guy who taught me, he was in his 80s when I knew him. He was around since they invented neurosurgery. He would shine lights through heads like this and as proof that it's hydrocephalus. So that's a problem. But there are lots of other reasons for bright blue veins of the scalp. So don't jump to conclusions. This is something else entirely, and it has nothing at all to do with hydrocephalus. And they're very blue. Eye movements. This classic eye movement pattern. Baby can't look up, is only looking down and out. On the intracranial pressure volume curve, you know how it accommodates and then it takes off. This baby is on the takeoff point. And if your baby has eyes that look like that, the baby should be in the ER or on his way to the OR, period. See, he looks upset too, right? Because he is. In the hospital, in the the NICU, we got all these monitors. There's lots of things. The apnea, bradycardia. There's lots of things to look at to raise suspicion of hydrocephalus brewing or worsening. But the whole, all the rest, the stuff that you kind of send the baby home with, are the things that are hard to interpret and hard to sort out for a family with a new baby. It's the sort of all the things that make the cartoon mommy cry. The tests, Dr. Means has covered this well enough. MRI is, of course, the classic. We have full MRIs. We have the quickie MRI that you don't need to be sedated for. You can get a very quick look at the brain and the water real fast. Again, the tiny face, the big light bulb head is hydrocephalus, period. So MRI is good. CT is faster, can be faster. Again, tiny face, big head. Neurosurgery, we do CTs because we need to see the bones. If we're going to be doing an operation on the baby, you need to know what the bone anatomy is. Karen Moeller, before she left, she worked with our CT techs to make the lowest radiation dose for a CAT scan in the United States at Downtown Children's Hospital. So we get CTs. Not many, just a couple. Ultrasound, quick, easy, hard to interpret. If you're going to be planning an operation of any kind, it's no good, no matter what they say. It really ain't. All right. How do you treat hydrocephalus? Oh, you don't. You call us, and we will come treat hydrocephalus. We will cheerfully answer whatever questions you have, and then we will sick our powerful colleagues on you. How do you reach us? 502-561-3123. 24/7. It will always be answered. You can send an epic message, which we won't see for weeks. Or CC a chart in through Epic. Yeah, we might find that each quarter when we clean up the charts. Just tell you the truth. Or text or call. But we are available 24/7. And there is one neurosurgeon first line and another one back up all the time. And these guys who take care of everything. All right. So how do we treat it? Okay. Well, there's the temporary treatments and the so-called permanent in air quotes. We may need to do something temporary for a neonate with intraventricular hemorrhage. You can't go to a permanent solution. You need something to clear the fluid, decrease the pressure, clear out the blood products, and this can be done over the course of days, weeks, or months. Currently, we mostly use VADs, ventricular access device, which is a little silicone thingy that sits outside the skull, and the little tube that sits in the ventricle. So there's a little tapping chamber, which then extends into the ventricle, and we come by every day or twice a day or every other day and tap, assess the baby, assess the head size, and some of the kids, they'll maintain their need for tapping and end up with a permanent solution when they're able to have it. Or they'll decide that they've cleared enough of the blood themselves and washed away the fibrous products off their filters, and then they'll go on a tap holiday, and we'll get calls from the NICU, you forgot to tap the baby. No, we're trying not to tap the baby. And the tap holidays can extend for a day or two or a week or a month, and some of the kids actually get away without the permanent thing. VADs are good. So in an emergency, you can consider an EVD, external drain. So there's a baby head under here, and this baby has just had 2 silicone tubes put into the ventricle for big bleeding. You'll do an EVD if you're in an awful rush for whatever reason, and this will be connected to an external drainage system. But we don't like them as much because water in the ventricle will track along the tube and then start leaking out the hole, and it'll only be a few days before that starts. And that's no good for anybody, because water comes out, bacteria goes in. So EVDs almost never show up in the NICU. They show up occasionally, more of an ICU thing. And they're temporary, but things have to be happening to get rid of them because they're not good. All right, next on the list is the subgaleal shunt, which is the same sort of a tube here, but instead of putting it out through the skin, you cut it off here and shunt from the ventricle to the space under the skin. And some places in the country find this to be much better than a VAD. The biggest problem with this is if you're shunting under the skin is stretching out, and your head circumference measurements are now complicated by fluid underneath the skin and water. You know, if you put it in with an incision and the water is sitting right there, it's inclined to come seep in through the incision. So we almost never do these, but some children's hospitals, that is what they do only. Dr. Duncan's still here. Back in the day, the fontanelle tap was the thing to do. The tired, exhausted, filthy neurosurgery residents would come around and stab the babies in the forehead with a spinal needle and take out 5 to 10 cc's of CSF. And that was, well, 25, 30 years ago, that was the way it was done. Boston Children's Hospital, that's how we did it. Yeah, I bet you did. Yeah. Exactly, because, you know, the neonatal skull, there's space, And then in the hydrocephalus baby, there's a lot of space. Okay. Yeah, ultrasound would work. Horrible. Whatever's on the skin, you're pushing into the baby's ventricle, dermoids, and all kinds of infections and things are the potential for that. And the frontal lobe with multiple fenestrations through it, not great. Really not the best way. So that's very rare. Occasionally you get a baby who is so sick that you have to do a fontanelle tap because you can't get them as far as the operating room. But pretty rare. And even rarer now is the daily LP, which used to be done by the neonatologists. I just literally can't imagine the 600-gram baby getting stabbed in the back once or twice a day. I think to dribble out a couple of cc's, I mean, my God almighty. But that's really, really not done much, if at all. All right, so those are the temporary things. The so-called permanent things, VP shunt or an ETV. So the VP shunt, a tube in the ventricle that runs under the skin to some other place. The peritoneum is most common. First VP shunts ever were in the 1950s. And the first successful ever in the setting of a fatal disease, hydrocephalus. They put a red rubber catheter in the brain, ran that under the skin, did a nephrectomy, and connected the red rubber catheter to the collecting system of the bladder. That was just the first successful treatment of hydrocephalus surgically. I met one woman who had that as a baby in Boston. At the time, she was a 40-year-old attorney. She got a proper shunt later. But that was a bad idea because whatever infections in the bladder went up into the brain, and then the siphoning, when you put the baby upright, the fluid would go straight out, and then the electrolyte imbalances, it was terrible. In the late 50s, a dad had a child with spina bifida, and the siphoning, he's like, this is stupid, you need a valve. He was a machinist. So him and the peds neurosurgeon there made the first valve for his girl. And that then became the first commercially available shunt valve and began the modern care of hydrocephalus. He made the first 500 of them himself by hand and then turned it over to some company to make them. This is the one we use mostly. It's really small. It's really well made. There are tons of them out there in the world. And a lot of companies have spent a lot of money trying to make a better valve and have added various bells and whistles. And as our invited guest speaker mentioned earlier, in India, this valve is used. So it's probably around the world one of the most used valves. These range from $1,000 to $3,000 each. This one is $25. This one will never be used in the United States because the cost to get it through the FDA, the company don't want to do it, not interested. All right, problems with shunts. There's lots of problems with shunts. You put a shunt in, you're stuck with it. How do I do this? So you have to manage them lifelong. You got to pay attention to them. You got to keep them functioning. So you put them in as a baby, like this guy here, and every year you look at his brain scan to see if there's something subtle changing. He shows up here a couple of weeks ago, ventricles don't look right compared to his baseline. He's now 17 years old. He's had one malfunction ever. And you can see on his shunt series that the tubing's broken. He's not acutely malfunctioning because he's got 17 years worth of a scar built around that tube, and that scar functions as a tube for years. And then one day it shuts off and you have an acute malfunction. Or acute malfunctions. You're sitting at home, some choroid plexus clogs up the little holes in the tube, nausea, vomiting, somnolence. Everybody who has a shunt is using it for some percentage of their hydrocephalus. 2%, 5%, or 100% of their water management. So if it's 100%, within 8 hours, they're critically ill, approaching coma. If they're on the 2% train, they can go for weeks or months without getting to that part of the pressure volume curve where they're sick. So if you have a shunt, you need to know where your children's hospital is. If you're traveling, you need to know how to find, the children's hospital near Disney or whatever. You need to travel with your scans, your baseline scans. So if you've got gastroenteritis, you don't get a shunt operation by some Yahoo in wherever. Infections. So everybody thinks about shunts and infections, and everybody's read about how shunts get infected, and it's mostly shunts get infected when you have a problem in and around an operation. So years ago, before it was fashionable, we worked a best practices concept and drove our shunt infection rate to close to zero, and it's been pretty much zero for quite a few years now. So it is possible to not be dealing with infected shunts, and I will tell you, the kids who don't get infections, their life with their shunt is dramatically better than the kids who get infections. All right, something new, endoscopic third ventriculostomy. Well, it's not that new. It's a couple of decades old now, but it's still being sold as new. Instead of a shunt, you put a little telescope in and put a hole in the floor of the third ventricle. This is that little 5-year-old, by the way. That's what his brain looked like at 5 years old of chronic, untreated pressure. So you poke the telescope in, and the goal is to get here and to put a little hole. Now you see that little place that you're going to reach has got the basilar artery sitting right next to it. So this is what it looks like. You can see some choroid plexus, the septal vein, the big thalamostriate, and you're heading down towards the floor. You can see the mammillary bodies. And you push a little further, and you can see the floor a little clearer. You get a little closer to the floor. Now we're looking right at it. The floor, this is the inside, the wrong side of the pituitary stalk, which is kind of cool, frankly. And then you're going to blow a hole here. And then after you poke through, you're now looking at arachnoid, basilar artery, pons, which is all very cool. But you're looking here, and all of this, what you've just been pushing through, you don't see. So occasionally, after you do this, you pull out to here, and you find yourself in a puddle of blood or something. I find these operations very nerve-wracking. Dr. Gump likes to do them, so. All right. So what are the problems with an ETV? Well, you need lifelong management. The promise was you'd make the hole there, the fluid would go around the outside, and you don't ever have a shunt It turns out the ETV has a failure rate about as the same as a shunt, because the little hole you make scars over. There is a ETV success score. So you'll notice that ETVs work best in old people, older. They work very poorly in babies and neonates. So for neonatal treatment, it's very rare in the first year to have a situation that the kid's going to benefit from it. All right. We hire people based on their appearances, and never mind. Maternal fetal medicine. These guys are out there beating. They're trying to find all the hydrocephalus that exists, and they keep finding ventriculomegaly and frightening their patients. So we get to meet these people prenatally. Tamina Singh forces me to talk to them, and I don't know what to say to them, mostly, frankly. So, you get an ultrasound, fetal ultrasound. It looks like a baby. This looks like an avocado, but apparently it's hydrocephalus. I don't know. That's what. Then they send them for an MRI, which looks like hydrocephalus. And then the families ask me, what am I going to do about it? And I have to tell them I have to wait until the baby's born. And they get very upset. Why are we here? It's to meet your neurosurgery team. You're not going to do anything today? No. So we wait till the babies are born. So this is, these are lovely and predictive, maybe. All right. So here's a case. In utero diagnosis of hydrocephalus, and you learned earlier today how bad this looks, right? Big water, small brain, bad. Or is it bad? Or how bad is this? What predictions? Guesses? So what it really depends on, in the 9 months you get, about halfway through there, and you can correct me if I'm wrong, all the little nerves find their way to where they're supposed to be. And it's about halfway through, right? So if the big squash happens before they get where they're going, the kids are not going to be good. If the big hydrocephalus, the big water squash happens after they get there, the kids have a fighting chance. So this dude, he got a shunt. He's got the look of he had a lot of pressure, but he's normal. And he is 100% normal. He is the third boy in this family, and Mom describes him as the smartest of the bunch. He's completely normal. How about this guy?
That's what happens when Dr. Moriarty operates on your brain.
Oh, wait. This guy, well, there's an awful lot of water. There's some calcifications. There's some fluid level. So what, there's only one thing in nature that gives you a perfectly straight line. It's a fluid level. So water and blood products. So calcification, blood, a hole in the brain over here. Small face, big head, there's pressure, but I'm not so sure what the brain's going to look like. And this guy got a shunt, and he didn't live 2 years because of his neuroimmune system, and everything's bad. So we can treat pressure. We cannot fix a brain that was not formed right. Here's a little kid comes into the office. My God, well, with a shunt a few years later, all the brain's there. The kid's fine. The kid's okay. Here's another in utero hydrocephalus with measurements. And this dad came in with an Excel spreadsheet of all the measurements they'd been having. Wanted to know exactly what to do about the hydrocephalus. And we got to wait till the baby's born. And then the baby was born. And it turns out there's no hydrocephalus, but there is actually microcephaly. And they have a whole other entire thing to worry about, which was different than what they worried about for the previous several months. Here's another newborn, massive compression, and completely normal. This is an early baby picture, or childhood picture, but she's a completely normal kid going to UK, actually. This is a guy, big hydrocephalus, but he didn't get all the parts where they were supposed to be before he got his big pressure problem. So he has a lot of challenges. He does not speak 3 languages. He might be interested in cars, but I don't know. How about this guy? So this guy fell down at school, fell off the monkey bars or something, got a CAT scan, and a helicopter flight to Children's Mercy Hospital in Missouri, I think it is. Kansas City. And they got an MRI. This hydrocephalus. He's got big ventricles. Does he need a shunt? Well, the peds neurosurgeon there was a Boston Children's guy from like 10 years before me. He looked at him and said, he's fine. And so I know him because 5 years later he shows up in Louisville, and his coach and the school need a note from me saying he's okay to play whatever he's good enough at that the coaches is involved. So 5 years later he gets another scan, and it's exactly the same. Hydrocephalus changes. It has to be changing over time. Static, big ventricles, that's the way God made him. He's perfectly normal. Here's another great example of, is this hydrocephalus? These are bigger than normal. A couple of years later, they're still bigger than normal. And this guy, he's completely normal. One last tale, and then I'll shut up. This is IVH. So big ventricles, you can see the blood. This is what a normal scan CT might look like. So this kitty gets a VAD, and there is a lack of attention to detail in the placement and care of the VAD, and he gets an E. coli infection of the VAD. And that's what his brain did with an infection. So the care of these little things, it needs to be exact. And then he got worse. And then he got several shunts. And he's ruined. I mean, just hospital-acquired damage. All right, I think that's it. So on behalf of the neurosurgery service, thank you, and I'll answer any questions you have.